fond memories.
Did you know the fastest growing population in the United States is the over 70 group? Although it is the fastest growing, it's often ignored. And here to shed new light on that very vital part of our population is Dr. David Staats, who's a medical director for the Council for Jewish Elderly and also the chief of the Division of Geriatrics at Mount Sinai Hospital Medical Center. Thank you so much for being here on Focus.
Thank you. It's a pleasure to be here.
I feel this is one area that needs not just a half hour, could use hours and hours of discussion, but for our time's sake, we're going to capsulize it. What is more crucial to an elderly patient's health? Is it the physical or the psychological well-being?
I don't think that you can divide the two, that the one has a relationship to the other. For old people, things that are taken for granted in younger people, like putting on your clothes, like being able to go out and go shopping, none of these things can you take for granted. That is why the health care needs of old people are broader than for younger people, and that's one of the messages of geriatric medicine.
What do you do when an elderly person just gives up, when you know they still have so much to offer, that the young can take so much advantage and benefit from that past experience, and they just say, I'm sorry, doctor, I've just given up, I just can't go on anymore? What do you do for that patient?
You raised several interesting points. First of all, the old people should never be written off. In our society, in our culture, to be old is perceived as to being bad. That's why the commercials on television say that you should put cream on your face when you're 25 to keep you looking young. So that is an important thing to remember. Old people in general tend to take things on a more even keel, and I don't know how accurate that is about giving up. Because they've loved and lost, because they've had this vast lifetime of experiences to build on, the old people take things more in their stride. You also have to make sure that somebody who says that to you isn't suffering from some reversible sort of illness. It may be the pain from their arthritis, let's say, that makes them feel bad. And it makes them feel bad not only because they have pain in their knee, but also because they can't get out and go to the store.
Right.
They can't participate. That's one of the great secrets of geriatric medicine, that sometimes by fixing the knee, if you can fix that arthritis pain, you do much more than simply reduce the inflammation there. You make an impact in terms of the old person's life by allowing them to be more independent, to take part in more activities.
Well, how do you convince the patient who has been independent all their life and now they are limited because of that pain in their knee and they can't walk around the way they used to? You know, doctor, I've been independent all my life and I wish I didn't have to be taken care of, in an institution. How do you justify it to them?
And there's one more point I want to make,
go ahead.
And that is, one of the things is that person who tells you, I want to give up, they may be depressed. Depression is very common, not very common, but depression is something that shouldn't be overlooked because it can present as bodily aches and pains, and that hopeless, helpless, given up feeling is something that may be completely reversible. Nothing is as happy to see as a patient who has been depressed. It's like watching a bulb come into bloom again. It's very important, too, because white males over the age of 70 living alone have the highest suicide rate of any demographic group, so that it is particularly important not to miss that diagnosis in people. And now, I'm sorry, I lost track of what your question is.
Okay, what I asked about the person who's been independent all their life. They've been able to go around at their leisure and just be able to hop on a bus, and now the arthritis in their knee, take that example, limits them. How do you help console these patients saying you really have to sit down, or in trying to make them more independent, just justifying that they have to be under the care, within an institution perhaps, and they have to sit down, and having them cope with that?
I don't think it's an all or nothing situation, and some of these things are more gradual transitions. But you have to work with what you have left. A lot of geriatric medicine is rehabilitative in that sense, because rehabilitation is not only the rehab hospitals, which help people with amputations or with strokes or with various other difficulties learn to walk again. Rehabilitation is tuning someone's medicines so that the side effects are minimized and the appetite comes back. It's also things like, I can't think of it at the moment, but there are other things that are rehabilitative.
Well, I was working with the family part of that rehabilitation, helping them cope with a parent's sudden inability to walk around as they used to. Do you work with the family too and helping them with their anxieties?
Yes, I thought of what I was going to say. Rehabilitation is also things like fixing people's eyesight. Today, cataract surgery has advanced a great deal. There are intraocular lens implants where you put a plastic lens in when you take the old one out, and this allows people much more vision. It's important in medicine not to equate old with being sick. This ageism that we talked about a little earlier creeps into medicine when people say, why, that's an old man and he can't walk just because he's old. That's quite wrong. What one should say instead is, that's an old man and he's sick because he can't walk. Why can't he walk? And that triggers the rehabilitative process. What you were saying about the families is very important too, that who is the patient? It is not only the person themselves, but also their spouse, who many times tends to be as old as the patient and tends to have some frailties too. That supporting that person may be tantamount to treating the older person. And the families enter in here too, if they're the ones that are part of the caregivers. It's much like pediatric medicine, and there are many parallels. The age group is heterogeneous. That is, an infant is much different from a teenager in the way that somebody 55 or 65 is much different than somebody who's over 90. And in the same way, you have to make sure that the mother is all right to treat the baby. In the same way, you have to make sure that the people in the sphere of an old person are able to help too. So it's very much that way.
You say there's parallels between pediatrics and geriatrics, but isn't there one area where we have to avoid treating the elderly as a child, and that tends to happen? No, you can't eat that, Ma. Now you know you shouldn't be doing that.
Yes, that's critical. That independence is tantamount to health in old people. And lack of independence is not only the arthritis that keeps you from walking, it's the inability to make choices. Today, people recognize that old people register to vote and lobby in large numbers. There are several people in Congress who wrote in on a ticket of helping elderly people. And so giving elderly people, even the infirm ones, choices about what goes on in their world is very important.
I know, and as a matter of fact, you have I will take a quote out, just happen to have, you talked about how people should not assume someone who's old is sick. You said old age is not an affliction, and I strongly object to the stereotypes about aging which are rampant throughout our society. And you continue, what most people don't realize is that older people are also survivors and have special strengths. What are those strengths?
Just having lived for 80 years is a certain strength, that the strong survive, and other strengths of old people. The wealth of experience that you have and the judgment that old people have. The creativity of many old people is astounding. If you look particularly at musicians and conductors, I watched the PBS program of Arthur Rubinstein at 90. There was an example of somebody. Verdi wrote his best operas when he was in his 70s.
They can use that experience. We have to convince them that they have to share that experience and that they are a valued part of our society.
And finding a way of intergenerational sharing, of passing on and utilizing that knowledge by younger people. That's why the role between grandparents and grandchildren is so very special, because it's like reliving raising their children all over again. But when they get messy, you don't have to take care of them all the time.
Just enjoy
you can
them.
enjoy them for themselves. And in the same way, for the grandchild, the grandparents are loving. They don't punish the grandchild often in the same way that the parents are an authority figure. And it's a very wonderful sharing. I have many very pleasant memories of my grandparents.
Is that what you are so profoundly interested in, taking care of the geriatrics? Is that what prompted and triggered your interest?
I had very strong personal experiences with the old people in my family, and my parents really showed me the way to treat old people. When I was in medical school and beyond in my residency, there were people around me, there were doctors, who took good care of old people. Doctors have been taking care of people for a long time, but they were especially important role models because they understood some of these things that we've been talking about.
You mentioned before, your special relationship with your grandparents, and you mentioned the special relationship that grandparents and grandchildren can have. How do you tell a grandchild who's been taking their Sunday walks with Grandpa every single Sunday? Grandpa, unfortunately, has been stricken with a stroke, and he's unable to walk. How do you explain to the grandchild, I'm sorry, Grandpa's still a human being, you still can have fun with him and still can communicate with him, but you can't take those walks?
I don't know. I'm not the expert in dealing with children. I think that you have to, depending on what the child's age level is, you can say that Grandpa is sick, and now Grandpa is having trouble walking. And then if they're really clever, they'll figure out something to do with Grandpa the way he is. Instead of going on walks, Grandpa would like to read with you, and we'll take a look at pictures of gardens or pictures of birds or whatever it is. I think that you can find a substitute for that. But the communication and the loving interaction, that's really what's critical.
Now, how does your specialty as geriatric medicine, how would care for someone who, let's say, I know you worked on a cardiology research project at the University of Chicago Billings Hospital. So let's take a cardiac patient, for an example, someone who's 40 versus someone who's 80. How will the care differ?
As far as the heart goes, I don't think that it will differ a great deal. There may be a little less reserve in the organ for people who are in their 80s and 90s and onwards. That isn't always the case, but usually the case. But it's the rest of the situation. Who is there when the person goes home? In the younger person who has a wife and so forth, that may be less of a problem than for an older person who may be living alone by themselves, who's a widow or a widower. And so it's the context of the aged person that makes the difference in the approach.
And is there more of a sensitivity? I know we've unfortunately been through the experience of my grandmother being in the hospital. We noticed that nurses and doctors tend to talk louder to the elderly, and I don't know if it's because of their hard of hearing. Their care seems to be a little bit different, the focus.
That's one of the things that's important to teach about how to communicate with somebody who's hearing impaired. Hearing impairment is fairly common among old people, especially among people in a long-term care setting. You must never shout at somebody. When you raise your voice, you have a look of anger on your face that's communicated. Instead, you should sit down with them at eye level so they can see you, so they can see your mouth moving. You should do it in a quiet room as possible so there's less background noise to interfere. And you should speak slowly and in a low voice. I also have gotten good at pantomiming with my patients when I say, and how are your eyes?
Yeah. Do you find you do
And
that
how
when
are your
talking
ears?
to your contemporaries, too?
I find that,
You
yes,
translate
I
it.
do.
Now, there's one area that we had discussed before. It's rather sensitive, but I hadn't even thought about it until I had taken the tour of the CJE housing projects, namely Leiderman and Schwartzberg Home, Robinow. But one of the social workers mentioned sexual activity among the elderly. This is something I never thought of. Is this encouraged?
Yes, but sexuality in old people raises many of our misconceptions about sexuality. Sexuality and the expression of sexuality is so much more than hopping in bed and making love to somebody. Sexuality encompasses gender role. It's feeling like a man or a woman. And part of that is grooming. That's why in long-term care facilities it's important to have a beauty shop and a barber shop so people can have their hair done, and for women in particular to put on their makeup, you know, to dress the part. That's a part of sexuality. Part of sexuality is being touched. And I think a lot of people are afraid to touch old people, and I'm not. The people in the nursing home, I enjoy touching them very much. Some of the old women like a peck on the cheek now and then, or a kiss on the
Why are
lips.
people a little afraid? I notice, are they afraid that it just may transmit, old age will transmit through touching?
I don't know if it's that or whether in the past it was not considered polite to be as open in your affection towards people. Whatever it is, people are starved for that. Or they may not have a family member or a loved one to be around to do that. So I think if people hugged each other more, the world would be a better place. And what else? Intimacy is a part of sexuality. Having a good friend who you can share your innermost secrets and your fantasies with, that's important too.
Just this, yeah.
And in long-term care, there are still people who may be sexually active. Yes, I can't, what I usually say, I won't say on the air here. But yes,
After the show.
after the show I'll tell you. But people may experience sexual activity long into their lives, into their 70s and into their 80s. And just lying next to somebody and hugging them and touching them, even though they may not achieve intercourse or orgasm, can be as satisfying.
It removes the loneliness that commonly accompanies, getting old. Which brings us on the subject of exercise. Just this morning, CBS News, it talked about exercise for the elderly. Would it be difficult to start someone exercising after the age of 65, 70? Would it be harmful or helpful?
I think exercise in moderation is good at all ages. What is the optimum exercise for people 65, 75, 85 depends on what their past life has been like, what their current medical condition is, where they're living, and how they're able to get around. I think that for most people, walking in late middle age, in early old age, is a good form of exercise.
Another part of keeping yourself fit is nutrition. I know we used to ask my grandmother, "What'd you have today?" She says, "I ate." "What'd you eat?" "I had coffee and a roll." But that's hardly a proper staple. I mean, it's a stable diet, but it is not nutritious. Do you also help with better nutrition for the elderly?
Yes. People who have lived to 80, whatever they've been eating is obviously sustained them to then. And it's hard to change eating patterns in old people. That's number one. Number two is, can the people prepare their own food? Do they have the money to buy it? Can they go get it? Can they see in order to cut it up and to cook it? That's all very important. Is there something in their illness that has made them lose their appetite? The differential, what causes loss of appetite in old people, is very complicated, and that needs to be looked into.
Well, how can you encourage the person who's the coffee and roll elderly person to, try and eat the cottage cheese, even if it's, make it more palatable?
Well, she may have had coffee and roll for breakfast. I've done that on occasion. And for lunch, she may have something much more nourishing. It's sort of a balance over the day. If you can find some way to provide a more nutritious thing than just a roll. In England, there were a lot of people who, for economic reasons, ate toast and tea and became iron deficient as a result. If you can provide some more nutritious food, For people who have a hard time preparing it, things like Meals on Wheels, CJE sponsors something like that. They call it home delivered meals. Right. That can be a useful supplement.
Before you talked about it's important to have a beauty shop and a barber shop and to put on a full face of makeup to feel healthy. But I know there are those elderly people out there who are afraid of looking too good. It's the superstition in Jewish, we say, kanahora. You know, you look good today, Graham, or you're feeling better. They don't want to admit to it, and God forbid if they look too good, they may not get the attention. Is this something you run into?
Yes, I think that's true, that people who are sick sometimes get more attention if they're well. This is the child, you know, who wants to stay home from school. It's fun because you get to lie in bed and mother brings you breakfast in bed and comes in and reads you a story and so forth. These things happen in a different way. I think in general people would prefer to be independent and active than to feel crummy, though. So saying you look good, saying that's a nice dress you have on, when you really mean that, do that.
Would make the patient feel better, or just the elderly person, the person feel better.
You see, you did it there yourself.
Which brings me, you've also served on task force on abuse against the elderly. And I don't know what I just said, talking about the patient. I just slipped there. Would that be a form of elderly abuse?
What?
You're referring to the elderly as a patient.
No, I think abuse of the elderly is something a little bit different. Years ago, people found that some children were being battered, were being beaten or other things. And then some years later, women started to say how they were beat up by their husbands. So that abuse of elderly people is merely one spectrum of domestic violence in families across the country. It occurs like when somebody's tied down to the bed and not given access to friends, when people, caregivers, cash the Social Security check and don't spend it on the old person.
Yeah, it's forms of child abuse.
It's neglect also.
What has been done to stem this kind of abuse?
Well, the social workers and law enforcement officials and a variety of other people dealing with this problem have banded together. The Congress of the United States has had meetings on this and task forces on it. In many states, there's what's called a mandatory reporting law, which allows and in fact requires social workers, ministers, pardon me, and other people who come across an abused person to report it to a central agency who then can develop a care plan for these people.
Hey, there's another, you've been involved in so many facets of the elderly. There's another area where you're very involved, is environmental design for the geriatric society. And, you know, it's just as important to have a physical, the physical environment is just as important as the physical well-being. What is being done? How is it different, the physical environment?
It's an example of how the limitations of some old people make them sicker. If you have a chair with arms, let's say, it's easier for somebody to get out of than if you don't have arms, if your legs are weak. So even something as simple as that can make a person more independent. That's only one example of how it can be. By having good lighting, even people with cataracts or various other eye disorders can read much better. Things in the bathroom, grab bars that are strategically placed, can make a person more secure. There are just a whole lot of things. That would require a separate talk, but that gives you a few examples.
This paper. I know there are some delicate decisions you have to make at times. In wanting to encourage self-sufficiency for the patient, you're treating a patient, let's say maybe at Leiderman Center, you'll still want this person to be independent and end up taking care of themselves. When do you decide to step back and say, okay, now it's up to you to put the food to your mouth. Now it's up to you to do this?
That requires a lot of input from a lot of people. When I was a fellow in Oregon, I sent a man home who lived in the woods. He literally lived in the woods. He had a dirt floor in the house. He had 8 dogs who he sort of slept with and gave him body heat. He had to go out for running water. To have institutionalized him would have utterly demoralized him. He was a wonderful man in his 90s who had a lot of arthritis, but he could still get along out there. His daughter looked in at him from time to time. And so to respect what is really important to the old person themselves, to let him make that choice, and to be willing to let people take a few risks is important. They're not fragile like eggshells that you have to put up on the shelf. They're like babies that you can bounce around a little bit.
Okay, there's another sensitive issue. There's a lot of people who say, and the families of an elderly patient will say, they're going to die anyway, stop intervening. It just means prolonging the suffering for the patient. Do you still step in to say, let's prolong it as long as possible? It's the quality of life that's important, or for the sake of suffering, to live longer? How do you make that kind of decision?
It is always a difficult decision to make, and various doctors have various limits of the things they will do or not do. Old people commonly die at the end of being old, and so that is something I'm used to dealing with. I think that it is not a good thing to prolong suffering, and that sometimes nature runs its course, and it's better to do that.
Dr. Staats,
I don't mean to suggest, on the other hand, that you should take your grandmother out and do her in like you do in an old dog in the family. Pets, by the way, are very important to old people. Pets can provide a companionship for old people that is not threatening.
We have very little time left, and I have a few more questions to bounce off you. What is going to happen when the baby boom becomes the granny boom, and all the people who are in the youth age now become old? Is there going to be enough geriatric care for them?
That's one of the reasons that I think geriatric medicine is getting going. I think and it's a society-wide problem, by what proportion of people are old in the society. In Europe, where the societies have done this, where a large number of people have turned old, it was one of the reasons I think that healthcare systems have changed. So I cannot predict the future, but I don't know what will happen. Maybe there will be a change in the way healthcare is practiced in this country.
Well, you certainly, Dr. David Staats, you certainly have helped that progression of understanding the elderly and treating them with the sensitivity you do. And on behalf of other people who do care for the elderly, I thank you, Dr. David Staats.
Oh, you make me blush.
Medical
That's very
director,
nice.
It's good coloring for television. Medical director for the Council for Jewish Elderly, and for Focus, I'm Deborah Palmer.
Sim shalom, tova uvracha, chen v'chesed v'rachamim. Sim shalom.